BioEthx Café. Café BioEth. Do older people experience a gap in quality of care?
Hi, good afternoon for you. The thing is, I'm a gerontologist. I work in a general hospital, and I also studied with Eva and when we made the BioEthx Magister. And I have a ward here at the hospital where we evaluate and keep on with the older people. But that is also something that has changed the last years. When I started 20 years ago, we used to consider older people over 65, and now it's over 75. So we're in constant change, and that makes us change the way we work, the way our nurses work, because we have to keep on moving as it's coming. I'll share with you a presentation. It's in Spanish, but I'll just keep on telling it in English, so don't worry about that. But so we can share. This presentation has two parts. The first part, we'll just try to describe the problems our older people are having right now. And then we'll speak 5 or 10 minutes about the problem that the COVID brought to our older people. I think that the two populations that were most affected by the pandemic were the young people and the older people, no? And we'll see why. The first thing is the medicines keeps offering us more and more things, and it's very, very difficult to know what is correct to do with each patient. We have more options, and most of them are invasive. So we have more things to do, and sometimes as doctors, we think that everything we have to do, we can do, we have to do it. No, the decision between what we can do and we have to do and when to stop is now the biggest problem in the elder people. The problem is we as doctors, the very, very first thing is we should not do harm. No? That's the only obligation we have as doctors, not to do harm. And the real thing is that many of the treatments we start doing now, they change, or they give our patients a longer life, but with a great, great impact in their quality of life. And we are not used to share these decisions with the patients, and most of the times the decisions only in the doctor, and what we are trying to change is that model, just to make decisions with our patients and to be real clear of not only the benefits you can have for your health, but as your quality of life. The problem we have is that it's not as easier as in other ages, because there's so many types of elder people. Now you have elder people that are working and they're active, and we have people of 60 years old that's not able to take care of themselves. So it's not as other statements in medicine where you can just say, well, we do this with every patient that has blood in the sugar, we'll give them metformin. With people that has hypertension, in the elder people, we have to adjust the treatment to each patient. So that makes it a little bit more complicated.
Okay, so I have a question for you.
Yes, of course.
So as you do this presentation, remember you're speaking to people who are familiar with the topic, right? So the question I have is, you say you are dealing with people with, even though they're older adults, they have different kinds of capacities, right? How do you distinguish who's where?
Well, that's what we talk about now. That's one of the most important parts of geriatrics. We have to adjust our treatment not to the age. The age is not the thing. The thing is how our patient works in his life and in society. That's what we call the geriatric evaluation. You have to evaluate different statements to see if your patient is absolutely dependent for everything and he's not capable even of taking decisions, or if he is able to have his life as he wants. So the first thing we have to do with elder people is not to look at the age. We have people of 95-year-old that's working and having a complete independent life, and people of 60 that are in a geriatric. So this is the first step in geriatrics. what I put here is the story of geriatrics. It comes from England. The first geriatrician was Marjorie Warren, and she was a woman. And in 1935, of course, she was not well seen by her boss, so she was sent to a place where there was not the real medicine as they used to see it at that moment. And there were a lot of patients that were living there and nobody didn't know why they're still there. They've been there for years, probably without family. And what she started doing is she started putting this different patients in categories. No? And her first question is, why is this patient in bed? Does he need to be in bed? Is he in bed because he's bored? Is he in bed because nobody is asking him to do anything? And she started to speak about different functioning, and that's the main step of geriatric, not the age, but how the patient can work. What we know, and this, yes, is common to every patient over 75, is that with the age, the illness comes in different ways. It's not the typical ways. It's easier to get complications. Probably something with 40 years old has a pneumonia. He's got the antibiotics at home and everything is resolved in 2 weeks. And something in some patient of 75, 78, probably he needs an admission. He needs antibiotics by the IV. He needs rehabilitation after that. The same pathology, it has different responses in the elder people. The other thing, it's more likely that our patient had a lot of medication, and sometimes these medications have different interactions between them. It's difficult after when something happens, that the capacity to go back to the previous state is much more difficult. And this is common to every patient, the one that's perfect and the one that's not. So we have to know this after we separate our patients, and then we have to know that even though he's doing great, he's in risk. No? Elder people are in much more risk to have complications during admission, during surgeries, than younger people. What's this of what do we do when we create these categories? We just have to do the evaluation of different areas, no? And this is a statement that's already, it's not that every doctor that's what he wants. This is already measured, and we know how to identify the problems and the risk. The only objective of this is to identify the patients that are in more risk than the others. And there are a lot of things that come from these evaluations, no? And when we want to mix up the geriatrics with the bioethics, there are things that always come out. One of the things that is the first one is if we should put a nasogastric tube for alimentation in patients with advanced dementia. This is a practice it was very common during the last 20 years. A lot of patients with advanced dementia still today are fed by a nasogastric tube or by a gastrostomy. And what we know about that after a lot of years of recording the evolution is that we don't get any mejora, any improvement for the patient. They have the same lesions, the same skin lesions, the same pneumonias. They don't get better. They don't start walking. They don't improve the cognitive impairment they had. So the only thing we do is we keep a patient stuck in the bed, most of the times with his hands tied because he's all the time trying to pull it off. So there's a statement from the American Geriatric Association from the 2014 where they say that we should not put a nasogastric tube in patients with advanced dementia. This is very difficult because after this is the family, no? And it's difficult to explain to the family that not feeding, feed has this thing with instinctive care, and the family thinks if you are not feeding the patient, you're just letting him die. And it's very difficult to explain that the patient won't die from inanición. It's not the cause of the death. It's part of the illness. It's just the last part of the illness. And we have to speak a lot about how we want this patient to be taken care, the difficulty to have him tied in the bed, and most of the families, when you explain this to them and you try to be clear and that there's no benefit, they accept. But there's a group of families that they don't. They just need to know that his father, husband, wife is being fed, and that's really, really difficult. It's a problem we also have with other doctors, that they still feel that if they're not feeding a patient, they're not doing good enough.
I'm sorry, I have a question for you. Is this the same thing between a feeding tube and the
gastrostomy? It's just the same.
It's the same thing?
Okay. It's the same thing. We are speaking about advanced dementias, not the same with a patient that had a stroke, because when you had a stroke, you have a time where you're expecting to get better and to rehabilitate. So it's not the same. This is patients with dementia. Part of the advanced dementia, that this is Alzheimer or vascular or Lewy disease, is that you forget what's the food for. So you look at the food, but you don't know what is it for. So you don't feel the need to eat.
Right.
So
okay.
you just stop eating. As you stop talking, that's another part quite difficult to understand. You start losing words and then you stop talking. The other thing that's quite difficult to understand is this thing of the withdrawal of the vital support. We try to use in Argentina. It's not as easy as in other parts of the world to use the advanced decision, that the patient could leave in a family or in the doctor, or written what does he want to be done when he cannot decide. Because today the doctors don't stop. This is what we were talking. We do everything to everybody. So we, as geriatricians, we try to speak with our patients about what would you like to have or to receive when you cannot decide. Would you like to be dializado?
Have dialysis, yeah.
Dialysis when you cannot decide. Would you like to have a feeding tube when you cannot decide? Would you like to be connected to a breathing machine support? Well, we have to talk about this. Doctors, we don't feel absolutely comfort with this, and sometimes we just try not to talk about this. Elder people are, if you take up the topic, they like to speak about this. It's different the way as they see life as younger people, because younger people do not think about death. But I think that as time goes by, the elderly people, they come to feel like that death is like a friend that will come someday, and they have quite clear how they've lived and what do they want to do in the future. It's much easier than with younger people. The problem is that sometimes we don't get comfortable with the conversation. And this is the statement I showed you. I just put it there so you can have it from the American Geriatric Society in this advanced dementia and feeding. This is what we are trying to do in Argentina. As you know, in Argentina, we have a quite diverse population. We had a great immigration during the first part of the 19th century and the 20th century. So we have different
ethnic groups, right?
Yes, and different ways to see life. We have, I work at the British Hospital. There are a lot of Anglo-Saxon people that are quite straight in the way they think, but we have a lot of Italian and Latin people that they are more dramatic and they don't like to speak about the end of life. And so it's not as easy as in other ways. We have a law here in Argentina that wanted to have this statement written for every patient over 60 years to the year 2020. Of course, that didn't happen. it's very difficult to speak with our patients. Sometimes when you start talking about this and say, well, what would you like to happen if you cannot decide? What, I'm dying? No, you're not dying. But what happened if you had an accident and you cannot decide? What would you like? Oh, is there somebody in your family that you want to take these decisions for you? That has a lot to do with the beliefs, the way the patient is being raised. So we couldn't make it obligatory. We want this in the law that when the patient got to the hospital and had to be admitted, he had to sign his relative directives, but we still stuck in the middle. In the middle came the pandemic, so we're stuck over, and we're just getting over this now. The most important thing about this is people has to know that they can write whatever they want and they can just go back whenever they want. So this is not an obligation. We can say today, I say, I don't want to be in the intensive care unit. I don't want to have a breathing tube, but tomorrow I'm not feeling well. I came to the emergency room and they offer me to go to the intensive care, and I can say yes, and it's okay. It's just in the case it's not the same to speak about this and speak about the options when you're feeling well, and you can think that when you're not.
Yeah, I want to take a pause here because Dr. Lickholm is going to be leaving us soon, and have and entertain any questions or comments from Dr. Lickholm. Do you have a hard time getting advanced directives from patients, or?
Yes. I think that as an oncologist, patients are, and it's true, we've made so much progress in the treatment of cancer. It's just amazing. And it's very hard as an oncologist to go to a patient and say, hey, we're going to do everything we can to not only, make this cancer, cure this cancer, but, to make your survivorship as great as possible. And then to turn around and say, but if this doesn't work, what would you, want us to do? And that's very simplistic, obviously. That's not exactly what. And so a lot of oncologists, and especially young oncologists, have a really hard time talking with patients about advanced directives. And so I just wanted to answer that question. But this is so good because I think that it's still really, really hard after so many years to talk with families about feeding tubes. The only thing that I think helps sometimes is to say, if you have a feeding tube, you'll have to be restrained. And there's actually a study that showed that when people said that they would want a feeding tube toward the end of life, when they found out that they would have to be restrained, and these were actually doctors and nurses that were queried, they said no. A very large majority said, no, I don't want a feeding tube then if I have to be restrained. So I'm so with you on absolutely everything you've said. So thank you so much. I wish I didn't have to leave.
Yeah. Dr. Rochon, do you have any questions or comments so far?
No, I have no question. Thank you.
Okay. Thank you. Thank you, Dr. Lickholm.
Thank you. Bye, everybody.
Okay.
Bye. Thank you.
Thank you.
Okay, go ahead.
Bye.
Go ahead, Dr. Finn.
Okay. I put this statement. This is from the New England in the 2010. And I always go back to this article because it's the first time that a magazine like the New England put something that had to do with the ethics and the advanced directives and how this impact in the doctors and in the patients. And it's not very common that the medical publications look at this area. So when we read this in Argentina, we still didn't have the law, and we're not even working in this. And what it came to me is that the most important thing of this article is that the patients felt better, but mostly the doctors felt more comfortable. The doctors felt that they were doing what the patient wanted and not just deciding by themselves. So I think that's another reason for us as physicians to take this chance to speak with our patients about the future and about what happens if things don't go as just we are expecting. Of course, we're always expecting that things will go well, but sometimes they don't. So what will happen at that time? And to know that this is also something good for the physicians, not only for the patients, but also for us. The other thing that sometimes is difficult in the elderly people is when somebody is at the end of life and has the symptoms that we cannot control. This very, very slight difference between the sedation or the palliative sedation that we use commonly in the hospitals and the euthanasia. Now we have these things in the people's head, not in the physicians, because most of us should know the difference, but sometimes in the family or in other part of the team, like nurses, or we have this issue sometimes with the psychologists that follow up with the end of life. And we have to know that really that the only difference between what we do when we are working with the symptoms and when we're really looking for the death of the patient is the moral intention. So this is very important for every doctor to know what is he looking after. If we are looking after to have our patient with the symptoms, the better control of the symptoms. And if that controls the symptoms, just give us a patient that's sleeping, well, that's not what we were looking for. We were not looking for, now I don't know what happens in the States, but here in Argentina, we're going over, and there are 3 projects of this to regulate the euthanasia in Argentina. And I think as a society, we're not ready yet. And as a doctors, we're not ready. We have a patient that has an intent of suicide, and as a doctors, we are obligated to restrain him and because we suppose that if he attended with his life, if he's not doing well, but we are trying to, by the way, open this door of the euthanasia with a society that's not ready. I've read that experience in Europe, and there are so many different things in this, and you really get this. I think we don't have yet the correct answer for which group will be really benefit from this decisions. It's not common in the elderly people. Most elderly people do not look for active. I read the other day, last week, of a couple of 92 and 93 that the story in the newspaper was something as romantic, that they have decided to die together. I think that we have to resolve other things in the medicine first and a society first, what we are looking for. Here I want to make a little stop. I want to speak 10 minutes because as a geriatric, we saw a great change in our patients with the COVID pandemic. It was amazing, I think. A lot of people never got the life they had before. We have 3 years since we recovered something like a normal life, and some of them are still trying to get over what we did. In Argentina, we had a very, very long quarantine. We had almost a year of quarantine, and that made the elderly people to stop doing their activities, not being visited by their sons, their grandchildren, not going to do the supermarket, or they were restrained at home, that their families leave the groceries at the door and then leave. So what we saw after that, and we start seeing it at the middle of the 2021, was terrible. We saw that people, as I told you at the beginning, I think that the children and the elderly people are the most affected, because children here in Argentina, they were almost 1.5 years without going to school, so that was a lot. And what we saw after that is that people couldn't go back to their lives as easy as we thought. We thought, okay, now the pandemic is over, the quarantine is over, we go back to our lives, and the elderly people couldn't. They were scared. They had a lot of medical problems that they were not attended during that year. they had lost these bonds, these social bonds that they had before the pandemic. So it was really, really difficult. And in countries like Argentina, we have to also put the economics in the middle. No, that they were those elderly people that they were supported by sons or that they had work. They lost the work or they lost their commerce or their activities during the pandemic, and this economic problem got to the elderly people too. We also know that as they were more vulnerable to the severe forms of COVID, they were this fear. We couldn't work with that fear. They're vaccinated, they're taking care, but there's a group of them. They're still thinking that if this comes back again, they are the first ones to be in the list of people in risk, and that it's very difficult to get them to go back to a normal life. It's really we see that the rates of depression almost duplicated in the over 75 after the pandemic. The other things is people that stayed 1 year at home without doing physical activities. We noticed a great aumento,
Increase
of sarcopenia, and it's not as easy because the only way we have to do to get over that is moving and doing physical activities, and they are weak. So now it's just like a circle. They cannot do physical activity because they feel weakened, and if they feel weak, they won't get better. So it's very difficult. And we know also that 45% of people who were isolated duplicated their consumption of alcohol, and this had also a greater risk in people over 65. They also increased weight, and they had a increased weight that's not muscle, so they lost muscle, but they increased weight, and this put in special risk the elderly people. This is what it's a very small graphic. What we can see here is we had, as doctors, the impression that our elderly people were really in risk at the first wave of COVID. We say, well, this is where we do not have vaccines. They are the most risk population, so we had to take care of them. And this is the first wave. And then we start seeing that we had other problems that came after and came even 2 years after. That's the second wave, the third wave that had to do with the restriction in detention. They're not coming to do their other disease controls. This thing of the sarcopenia, they're not walking, they're not doing physical activities. And what we're seeing now, that was last year, is the depression. No, they have this isolation and this in difficult to go back to the life they had before, increased it in the psychic disease. And the elderly people show depression not as sadness, but they have anhedonia. Anhedonia is this thing that everything is the same. You have to offer them a lot of, well, would you like to go outside? That's okay. Would you like to do and why you're not doing? No, I will. But everything is the same. And when you ask them what gives you pleasure, anything, nothing. It's just everything's the same. And that anhedonia is what we see in patients now. It's not easy to treat. It does not have the same response as depression to the treatment we have with younger people. And as we know, depression comes with cognitive impairment. So as the rates of depression rise, the cognitive impairment also rises.
I have a question for you, if you don't mind. We're talking
Yes.
about COVID, and I know we're going to go into a very important subject here on behavioral health or psychological health, which is, I think, is important. But before we leave that topic off, the impact on COVID, do Did you in Argentina see any kind of, I want to say, sort of preference or deference to elderly people? Was there a problem when you came into the emergency room that if you were considered to be older, they sort of put you to the side and favored those who were more able? Did you have that kind of situation happening?
Well, in Argentina, I participate in we made when we just started the pandemic, we had a little advantage is that we had 2 months where we were seeing what was happening in Europe. So we had that little gap just to see what we wanted to do. The Society of Internal Medicine, they worked out like a algorithm where we would not take the age. We just take the function, the abilities, the social role. So we did not put preference just looking at the age. Probably if you were old and you were in a geriatric and you were not eating, you were not the first one. But if you were at home and you were working and you had a perfect normal life, even though you were 80, you would got the same treatment as somebody of 40. We did that from the very beginning, so I think we could.
And how did that work for you guys? Because I know that theoretically that would be normally the case, but during COVID time, when we had a huge influx of people coming into what we call the emergency room, which is where people come in as urgent care. And at that point, it was so overwhelming that a lot of our nurses and technicians were reacting, right? They were during the triage, they were, but there was no documentation of control of who got what where. Or I don't know if you had the same experience or if there had been any looking back documentation on what did occur so we don't do this in the future. Did you have that? I know you had the policies in place. I wonder
we had the
how
policies, and we have I can send you we looked over it 2 years after.
Oh, you did? Okay.
And I think we did. Of course, it was not perfect because, as you said, at some moments you were overwhelmed. But this checklist that we did, I think that what we didn't want to is just to leave people that were perfectly that they could receive, capable to receive treatment off. That's what we were seeing in Europe, and we didn't want to do that. So we also didn't want to use a breathing machine for someone that came from a geriatric and did not recognize his family for the last 3 years. So we had to everybody had attention. We did not send people back to their houses. That made that our hospitals were, because even you were very, very old, you stayed in the hospital, and we had quickly made a visit protocol, because this thing of very old people dying alone, it also made a lot of we were not comfortable with that. So the pandemic in Argentina officially started in April, and at the middle of May, we already had this protocol, so the family could be with the patient. Of course, we had a lot of things to complete, and we provide them this security mask, but they could be with the family.
Thank you. I didn't mean to sidetrack you so much.
No, I think it's very important because the COVID showed us the most vulnerability of this group during the pandemic and after.
Right.
We were surprised as what happened after. Because we thought as young people that, well, the pandemic is over, we go back to our lives. And for the older people, it's not as easy.
And here you have mental health consequences. I think that's what this slide is.
A lot of mental health. We have almost, as I told you, 45% more of depression. And the cognitive impairment also raised. And at this point, we do not know if the people already had a mild cognitive impairment and he spent almost 1.5 years without any social interaction, and that got worse, or if the COVID and the isolation had something to do with the cognitive impairment. the problem with the family also, because families, they didn't want to infect their older people, so they didn't even visit their older. So that's also brought a lot of depression. This is what I was saying, that the psychics repercussion problems were the most important. I think that probably Argentina had a very long quarantine. I don't know if this happened in other countries. As we read, in most countries, the quarantines were 1 month, and then they go over to normal life, and then another 2 months, and that's what we read mostly in Europe. In Argentina, we had almost a year complete, straight, without any interruptions, and that was a lot for our elder people. The other thing that we saw is the increase in the medication. The people start to auto-administrate clonazepam, bromazepam. As we had habilitated this as a telemedicine, they just got the recipe, and they start, a lot of patients that did not need anything for sleeping they start using this medication. And we saw something that's not common: 6% of elder people with suicide intents. That's not common. It's not an age that has this rates of suicide intents. The problems are different. Well, we saw this almost at the end of the 2021. We start seeing elderly people with suicide attempts. The other problem that we had, I don't know if this is in the whole world, is this thing that we had elderly people isolated in their homes with a television. And television keep on all the time speaking about how everybody died and the dramatic of the situation, and sometimes they were real things that would happen, and sometimes it's this thing that we don't have anything to talk, and so we just keep on talking about the pandemic and how terrible it is, and now there's another wave and it's even worse than the last one. And well, that excessive of information also brought a lot of consequences in our elder people. This is from two geriatric magazines. They are from Spain, and they also saw that after COVID, they saw an increase of
mental health
issues, just as we saw in Argentina. I couldn't find anything about the States. I don't know if they haven't written this, or maybe because the quarantine were smaller, you don't have this problem. But we asked the other country that had a lot of quarantine was Spain. Spain also had a problem. It was intermittent, but it was long, and they also had a lot of mental issues. This is something we did at the hospital. We asked the patients to write a word that identified the pandemic in the 2020 and the 2023. And as you can see, the words are very alike. The first word is
uncertainty.
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 Yeah. Uncertainty. Anxiety. They are scared. They are sad. So the words did not change, and this for us is the size of the words that has to do with the quantity of people that wrote that word, huh? And it was a surprise for us, because we think that in the 2023 most of these people should have moved over the COVID, and they should be better and going back to their usual life, and this does not happen with the elderly people. We're trying to work with that, at the hospital, we made workouts just to invite older people to do physical activities, to do, we have a literature taller.
Mm-hmm.
I don't know how you say that. Well, they read, we send them short stories, they read it at home, and then they come once a month and they have discussions about the short stories. We're trying to get them out of the house, and it's not as easy as we thought. Well, this is the things that I would like you to keep from, and this has a special look in Latin America, because we have also economic things in the middle, and I think that's not less important. Before COVID, elderly people, they already have economic problems, and they did not have all the possibilities as to have a very healthy vejez. But what we saw after COVID, that this got worse, that the physical, but then we have two great affections, the psychological one and the physicals. There are a lot of people that are not independent anymore, and they were before the pandemic. The economic impact in the families, not also in the older, but the families that they support these older people. This is from the Latin American Observatory, and they also see that the two groups that they think that it will be more difficult to go back to the normality is the elderly people and the youngs. The children, of course, that they were almost 1 year out of the normal life. And this thing that governments had to put money, a lot of money in treatment this pandemic, and they took that money from other government policies that helped elderly people, so that all those things were stopped, and they're, at least in Argentina, they're not back yet. We're just waiting that in some moment will get better and they will be back, but they're not back yet. This is the economic impact. Of course, as always, health and economics, they go side to side. If you don't have opportunities, economic opportunities, and if you don't have health access, everything goes together. And we see that elderly people are more affected than the rest. And well, this is just to at the end, we know that with the COVID, the death rates were more in the elderly people. We already knew that when we started the pandemic. Now we know that they have physical and health mental problems, that their economics were in problem. And what we also are trying to look at here in Argentina now, this is from Colombia, is that some of those people that were confined and they had another people to take care of them were suffering of some kind of that children and elderly people, they also suffer violencia.
Violence.
Violence, but this is a word specific. I don't know. It's not violence, but in this relation of.
No es violencia, ¿qué es? No es violencia, ¿qué es?
Es maltrato.
Oh, treated poorly by
treated
people.
Poorly by the as you strain the people that should be taken care. They're also having economic problems, and you see that in that chain, they are not taking good care of the elderly people. Mm-hmm. We do not have Argentinian data about that. Something that we are used to ask and to register, so we don't know. But it's something that we should start looking at. And nothing. This is just for to finish. You can just read it after. This is the British Medical Journal. It was in the middle of the pandemic, and I liked it because it spoke about how we were living and how we were dying, no? And it moved us to start these things that I told you before, that the COVID has a lot of things to teach us, and the way the older people were living and were dying. I had a lot of patients that called me and said, I prefer to die of COVID, but I want to see my grandchildren. I don't care if I live 2 years less, but I cannot still keep on with this isolation. And or just let me know, I have fever, but I don't want to go to the hospital because I don't want to die alone. And a lot of things that in the middle of this problem we had, and I know it was overwhelming, but sometimes we just lose this, and we were not just taking good care of our elderly. I think that dying alone is something we cannot just let it happen again. It happened with the COVID, and we should not let it happen again. And now 4 years after, we know it was unnecessary, but we did it. So just try to learn about this, try to see that the impact is much more deeper than what we thought, and much more important than in younger people. And nothing, I think now we have to just try to work with that and see how we get it back. I don't know if someone wants to do.
Yeah, I love the fact that this thing, Love and Dying, where you say nobody should die alone. We had a lot of problems here with nursing care or long-term nursing facilities with that, where family members couldn't come and see the people in the nursing care facilities, and yet there was a higher rate of COVID contamination there. I don't know, it just was and I think in the prisons as well, but in the nursing care facilities where it affects the older people. So Nicholas Turney, you have your hand up.
Yeah, I have a question. Going back to the previous beginning of the presentation, one thing that I'd like to know about is with the elderly, family have a big impact, or can have a big impact. And I'm wondering how you regulate or make sure that a patient is not being bullied into making a decision for their care. I'd love to know how you deal with that, please.
That's very important. We try, that's why we always encourage our doctors not to. It's not a checklist that you have to complete in 5 minutes. You have to start talking with your patient about this. A lot of times, not just once. You have to know your patient. Sometimes we ask them to take this formulary home just to read it, to talk with the family, and then when they're just getting the idea of what, and sometimes we say, okay, just do not put what you want or you don't want. Just put somebody that will take the decision for you, someone you really trust, and that person will take the decisions for you. But it's not a 5 minute thing. It's something you have to speak a lot with your patient, just not to get to put anything.
One of the things I recently was in hospital myself, and next to me was an elderly gentleman, and his son came in, and I heard the conversation, and he said, when you come out of hospital, we're going to sell your house, you're leaving, you're going to come back. And he was frightened. He was very frightened because I'd spoken to him prior to that. And so what I did, I took it on myself after the son had left to go and see the matron in the hospital. And she assured me they would have a conversation with him to make sure that he wasn't peer pressured when he went home. They were going to tell him what he could do himself to look after his own personal safety. So I wonder if that's the sort of thing that you would recommend. Thank you.
No, it's a very difficult situation because, as you said, you do not have only the patient, you have the patient and the family, and you have to get them all together. We always try to encourage the patient to tell us what he thinks and what he wants. And most of the times we try to have these conversations with somebody of the family there. So they can listen what the patient wants. It's not as easy as sometimes the patient does not want to go, does not want to contradict what the son wants. And he said, well, he's young, he wants to, but we try to get to the patient's decision. Right. And we always try to facilitate the going back home.
Yeah. I think that taking care of the older population has so many components to it. Not just there's medical decisions that you have to do that have to take into account the age and condition and psychological welfare of the patient, but also on the psychological side, even though they're capable of making their own decisions, there's a different viewpoint from the caretaker and the doctors and things like that. So I think it's a complex topic, and this is a great start for that topic. And I'm hoping that you will support us and delve into these themes about older populations, which are just one aspect of bioethics, and how do we make sure that we provide the same ethical care to taking care of the older population. I admire your work, and I think you've done a fantastic job in presenting it. So I want to thank you very much on behalf of the BioEthx Café.
Thank you for the invitation. It's wonderful to see that there's a lot of people interested in this issue. So thank you so much.
BioEthx Café. Café BioEth.